Hello, everyone. Thank you so much for joining us today. I hope you all are having a phenomenal meeting. So I want to welcome you all to our program today entitled Pharmacist-Led RSV Immunization Strategies, Leveraging Trust to Overcome Vaccine Hesitancy. So I'd like to start with introducing myself. So my name is Dr. Jacinda Abdul-Mutakabbir, but I go by Jam, like peanut butter and jam. Feel free to call me that. So I am an assistant professor of clinical pharmacy at the University of California, San Diego, about two hours away. And I teach in the School of Pharmacy at UCSD, as well as in the Division of the Black Diaspora and African American Studies. So I currently practice in a multitude of capacities, but the one most relevant to this is I develop vaccine clinics and provide vaccine education within minoritized communities in San Bernardino and San Diego County. So I will pass the mic to my esteemed colleague who will be joining me in this presentation, Dr. Richard Dang.
Thank you, Jam. Hi, everyone. My name is Dr. Richard Dang, and welcome to Los Angeles. I am an assistant professor of clinical pharmacy at the University of Southern California, so this is our backyard, our hometown here, so it's a pleasure to have you all join us here at the city. At USC, in addition to being faculty, I'm also our assistant director of our residency programs, as well as I'm involved in our outpatient pharmacy clinics, which includes our international travel health clinic, which is where I've been having a lot of my expertise in immunizations. And then during the COVID-19 pandemic, I helped Los Angeles City run our COVID-19 mass vaccination clinics. So if you visited or heard about our mass vaccine clinic site at Dodger Stadium, we were involved in that, and that was a really great experience to be a part of. But yeah, so it's a pleasure to be here with you today for our topic on RSV vaccines, and I'll pass it back to Jam to get us started.
Sounds great. Thank you so much. So I'd like to begin with thanking PeerView for providing this session, and we'd also like to thank GSK for being our purse, right, and for funding this with an educational grant. So as a reminder, well, your hand clap, right? Enjoy your lunch, right? Thank you, GSK. As a reminder, look out for additional follow-up polling during this presentation, and then you all can go ahead and submit your questions, and we will be sure to answer them during the Q&A. Dr. Dang is actually going through the questions now. We are really excited to get to them. So at the conclusion of this lecture, or our goals for today, are one, for you all to be able to recognize which adults are candidates for the RSV vaccination. Two, for you all to know or be able to provide the RSV vaccines as indicated. And then finally, for you all to know how to counsel patients to help overcome vaccine hesitancy and other barriers to optimal implementation of vaccination strategies. So we will go ahead and we will get started with identifying candidates for RSV vaccination. Who is it that we feel that should be prioritized? So when we talk about respiratory syncytial virus or RSV, RSV is one of the most common infections, and we see it commonly in childhood, but we do see it more so it comes back in late adulthood. So as I said yesterday, if you all joined us for the presentation, we do not call folks that are 65 and up old, we call them seasoned, okay? So that we use that terminology throughout, seasoned. And actually, my ministry that I work with in San Bernardino, they told me that the older you get, the more golden you become. So we use seasoned and golden interchangeably. So we do see that come through, and when folks do have RSV, we can see it either be asymptomatic or it can be severe, causing a lower respiratory tract infection. So in many folks with mild RSV, it can be undetected, but when we think about the lower respiratory tract infections, they can then lead to pneumonia or an exacerbation of chronic illnesses, including asthma and COPD. So what we see with that highest burden of RSV, once again, we see it in that early childhood, and then we see it throughout the aging cycle. So once we get to that 65 and up and above 70 years old, we can see that remanifestation, and that being with immunosenescence, right? We lose immunity to things that we may have seen when we were younger throughout our age cycle. So when we think about RSV in older adults, so in those that are older or equal to 65 years old, we see about 60,000 to 160,000 hospitalizations, and we do see about 6,000 to 10,000 deaths. So when we compare this to influenza and COVID-19, we do see that RSV, it doesn't exist, or we don't see as many cases of infection as we do with influenza and COVID-19. We see those spikes, right, with COVID and influenza. But we do see, as we move through that timing period, the infections kind of coexist together. So while we might not see as many infections as we do with RSV as we do with COVID and influenza, we do see increased severity with these RSV infections, predominantly because as we think about our patients that are not older, right, that are seasoned, that are golden, we think about their other comorbidities, and when you add a virus on top of that, we can definitely see that increased need for additional supplementation, or we can see that increased risk of just the worsening of that disease state. So we see that here with this study that shows us an increased odds of the need for oxygen supplementation, that being the high flow nasal cannula, or an ICU admission, or the mechanical ventilation and death with those patients that have RSV in comparison to COVID-19. And then as we compare RSV to influenza, we're once again, right, seeing that increase in severity. So I want us to leave this slide thinking or knowing that irrespective of the fact that we don't see RSV and access, so we don't see the same number of infections in comparison to COVID and flu, we do see that increase in severity. That's something that we should definitely be concerned about. So why is it that we should be even more concerned about the fact that we have this increased number of infections? Well, we know for COVID and for flu, we can give a treatment should someone be infected. With RSV, unfortunately, we're not in that same place. So vaccinations are our best measure for ensuring that we can protect folks from this virus. But when we consider this RSV, when we consider the virus, when we consider the availability of the vaccine, there is consistently low uptake for this vaccination that's been available. And I think for us sitting in this room and considering the communities that we serve, we know that this is likely magnified among those individuals that identify of a minoritized group. So here we are back at our question with Ms. A. Ms. A is a 64-year-old Black woman who has COPD and asthma. She recently retired from a civil service position, lives with her daughter and her preschool-aged grandchildren. She is visiting the pharmacy to pick up her medications, and she asked about a poster regarding the RSV vaccine. So when we think about this, and when we're thinking about our patients, right, that are coming in and asking about this vaccine, we immediately think, well, what is it that the recommendations tell us to do with this vaccination? So luckily, right, the ACIP, or those folks that make those decisions about the vaccines and where it is that they fall, they had this meeting in June 2024. And what they decided is that folks should receive a single dose of the RSV vaccine, and that those individuals that should be prioritized, or those that should get that single dose, should be all adults aged 75 years or greater or equal to 75, and then those that fall within that 60 to 74 years age range that have the increased risk of RSV disease, meaning that they have comorbidities or other factors that would put them at increased risk for this. So prior to this recommendation, we knew that folks 60 years of age or older could receive that RSV vaccine, but it was that shared clinical decision-making would be used to make this decision. So that has since been supplanted, and now we have 60 to 74 with increased risk, and then those that are equal to or greater than 75. So when we think about this and why it is that the ACIP went back and they reevaluated their shared clinical decision-making decision that we initially had in that June 2023 following that meeting. So when we consider that, well, in addition to the benefits of the RSV vaccine, that shared clinical decision-making was shown to be a bit harder. It wasn't that definite recommendation that we would typically see from providers and so on, which made it a bit harder for folks to go ahead and say, all right, this is a vaccine that I should receive. So what they felt was that, we needed a call to action. We needed for us to have that specific age range to say, you know what, we can strongly recommend this for these individuals. And then also when it came down to the Guillain-Barré, what we ended up seeing with the GBS syndrome, it tended to be, okay, well, if we're going to have this risk, who are those folks that should be prioritized, or who are those folks that would need this vaccine to where the benefits would outweigh whatever risk it was that existed with that vaccine. So now we have that risk-based recommendation for those that are 60 to 74, and for those that are equal to or greater than 75, we have that definite recommendation of receiving that RSV vaccine. So when we're thinking about who are those folks that have those chronic conditions, or what chronic conditions coincide with an increased risk factor, well, we have those folks that have their chronic cardiovascular diseases. When we think about that being heart failure, coronary artery disease, congenital heart disease, so on. Chronic lung diseases, so we talked about the increased risk, right, with asthma, COPD. Chronic kidney disease, so that's as we move through those advanced stages of kidney disease. Diabetes with end-organ damage, severe obesity, any type of immunocompromising disease state, neurological, neuromuscular disorders, liver disorders, hematological conditions, so that being sickle cell disease and so on, frailty. So a question came up yesterday of how it is that we define frailty. So I want to leave you all with the fact of the matter that we do not have a definite definition. However, there have been studies that have been published that consider gait speed as a measure of frailty. That's something we can consider. Those folks that are residing in nursing home, long-term care, other chronic diseases or risk factors that a healthcare provider can assess and say, you know what, this puts you at increased risk of RSV. Those are the things that we are considering for that risk-based recommendation. So now we have, just a visual of just those things that can increase your risk for hospitalization. So when we're looking at this, right, we're seeing for those folks that do have COPD, heart failure, hematological malignancy, stroke, chronic kidney disease, we're seeing that increased risk now in hospitalization with these comorbidities. So these are definitely those. If you have folks coming to the pharmacy, you're interacting with them, they tell you that these illnesses exist, you're definitely going to have that heightened train of thought, like, okay, this is someone that we definitely want to recommend the RSV vaccine to. And what we see specifically, so we're really pulling out what are those mediators, what are those chronic comorbidities that can go ahead and increase risk. We see chronic kidney disease, right, being a key mediator there. And especially when we get to that older age range, so that definite recommendation of 75 or older, we see an increased risk, right, of that hospitalization in that age range with that chronic kidney disease. So that's definitely something that we want to keep in mind. And of course, we know that chronic kidney disease goes by stages. You can see an increase in that stage progression as folks age. So definitely something to key our minds to. And now we see these risk factors amplified at the intersection of race and ethnicity. So now we see this comparison, right? So when we compare minoritized groups to their non-minoritized counterparts, we see increased risk in these comorbidities. I know specifically in the community that I serve, my group and I have been able to do research, and what we saw were that Black patients and Hispanic or Latino patients were more likely to have chronic kidney disease, and that chronic kidney disease can cause a worsening in other infectious ailments, including RSV. So definitely something for us to think about. We do not necessarily see that same increased risk with our Asian ethnicities. However, it's something to consider when we're thinking about data. Very rarely is data disaggregated, right, to the fact that we can actually look at disparities that may exist across different Asian subpopulations. So while we may see this low number, it may not be low for every single ethnicity subpopulation group. So we're definitely seeing these comorbidities be amplified when we think about racial and ethnic minorities. And then once again, we're seeing it be amplified for those folks that live in long-term care. When we think about long-term care, right, we have those folks. We talked about frailty. We talked about aging, but we also need to talk about congregated living. When you have people living in a place and they're very close together or they're interacting together, we can see that increased risk. We did see that the overall incidence of RSV for community dwellers in comparison to long-term care residents, we see it be increased, the increased risk of the attack rate, and then when we think about complications and so on, definitely amplified in long-term care. So what can our role be? What can we consider as pharmacists thinking about how can we increase vaccine uptake? Because we talked about the comorbidities, we know the risk is there. Well, first and foremost, we can run reports in our practice. We can review records and prescriptions for health conditions that indicate the need for RSV vaccination, so diabetes and so on. We can inquire about RSV vaccine needs. And then per the CDC recommendation, we as pharmacists can go ahead and assess, whether a patient is eligible, whether their chronic comorbidities fit. And the CDC also says that a patient's attestation, so them telling us that they have these comorbidities, is good enough to consider it as them identifying with the risk factor. So we are going to follow up on that polling question. So Miss A, 64-year-old Black woman, has COPD and asthma, lives in a multi-generational household with preschool-aged grandchildren. Is she a candidate for the RSV vaccine? So we're going to go back now after I've given you all information, and we're going to figure out, is she someone we will consider? So 1, no. 70 is the minimum age. 2, yes, it will protect her and her grandchildren. 3, yes, COPD and asthma are risk factors for severe LRTIs. And then 4, we're still not sure about the answer. And if we're still not sure, then I didn't do a good job. So go ahead and scan to answer, and then we'll have a comparison. All right, fabulous job, group. Okay, I'm not sure. All right, I'm not doing a good job. We'll leave it to Dr. Dane to pick up the slack. So when we consider this question, yes, so absolutely, I agree with you all. So we had no one that selected no, so at the very least, right, we know that there's 60 to 74 for the risk-based recommendation, and then 75 and older for that definite. And then we have, yes, it will protect her grandchildren. While we don't have data that specifically says that it will protect her grandchildren from getting RSV, is never a bad thing to be protected against an illness, right, that can be transmitted to others. For the other one, we have, yes, COPD and asthma are risk factors, 100%, absolutely. So that means that we listen, right? COPD and asthma can be risk factors, at least for increased opportunity of exacerbation. And then for the I'm not sure, I hope that by the end of the presentation, we absolutely are. So we will move on ahead. So is Ms. A candidate for RSV? Dr. Dang, I would say she is. She's definitely someone that I would recommend the vaccine to.
Absolutely. Yeah, and Dr. Jam went through a lot of information, and just to kind of reemphasize, these are new recommendations. So this is kind of like the newest recommendations that we have on. They are different than what we had with the last respiratory season as well. These recommendations were approved in June, like you mentioned, and they were also just published this week in the MMWR. So these are very fresh new recommendations. So it's okay if you weren't sure or a little bit confused, because we're all learning how to reapply these, because this is a different approach than we had in the previous season. But this patient is a candidate.
100%, absolutely. Thank you so much, Dr. Dunning. So I will go ahead.
Thank you, my turn. All right, some other key things just to reemphasize all the things that we learned. We now have age-based recommendations. So anyone 75 and older, universal recommendation, period, everyone should get that vaccine. Ages 60 to 74 is now a risk-based recommendation. That is very similar to shared clinical decision-making, but there is a list of conditions that places patients at high risk. Now, this is really nuanced, and unless you read every single word, which you didn't need to, you might have missed it. But that list of conditions that Dr. Jam presented included things that are very common, like cardiac conditions, like heart disease and heart failure, but it excluded hypertension. Right? So that's a very common condition. It included diabetes with evidence of end-stage disease complications, so with CKD, with retinopathy, et cetera, not just simple diabetes. So that's another major change. And it definitely included CKD. Like, that was very clear on there as well. It included respiratory conditions like asthma and COPD. But I think for most of us who maybe work in an outpatient, community-based type setting, hypertension and simple diabetes is not actually a risk factor for vaccination for that particular age group. So that is important to kind of point out the difference between last year and this year. Now, the last point on that condition slide was any condition that your provider deems as high risk. So that also is open-ended. So if you as the pharmacist or the primary care provider deems that the patient is high risk because of XYZ, there is still that indication for them to receive the vaccine. So you're not restricted in that sense to just those conditions. But those are some nuances that we want to make sure that is very clear as we continue to move on and apply some more of these ACIP recommendations. So this next section, we'll talk a little bit more about some of those details. We go back to one of our patient cases, Mr. B. So Mr. B is an 82-year-old male widower of mixed race who lives independently in an over 55 community where he keeps himself physically active. His medical history is significant for hypertension and benign prostatic hyperplasia, controlled with lisinopril and dutasteride and tamsulosin combination. He goes to the pharmacy for his annual flu vaccine, and the pharmacist discusses the option of RSV vaccination with him. So let's keep this patient in mind as we talk more about how to apply some of these newer recommendations. So as we get started, there are now 3 RSV vaccine products that are available on the market, and that's one more than last year. So what we have is 2 protein subunit vaccine products. That includes the product Arexvy from GSK and Abrysvio from Pfizer. So those are the 2 that we did previously have in the last vaccination season. New to this vaccination season is an mRNA vaccine. Now, you're familiar with that because of our COVID-19 vaccines. So now we have another mRNA vaccine, but for RSV, and that is from Moderna, and Resvia is the name for that one. So we have 3 potential options. Now, as far as our older adult population, there is no preferential recommendation of one product over the other. So you can use any of the 3 that you have available, and that would be considered appropriate and equally efficacious from the point of the ACIP recommendation. There are some differences in terms of some of their indications. So the Arexvy product, which will be referred to as the abbreviation RSV pre-F3, that is the one that is FDA approved for ages 50 years and older. So you see there's a difference in that as well. Then the Pfizer product, Abrysvio, which is abbreviated RSV pre-F, that is the one that is approved for 60 and older, but also for pregnant women. So that is the only product that has the indication for maternal pregnancy. And then for the mRNA vaccine, that is the one that's approved currently for older adults 60 years and above. So those are some of the differences in terms of their FDA-approved indication. But as far as their ACIP recommendations, we will go by that. So in this case, there is a difference between FDA and CDC age recommendations. Currently, the CDC has not made recommendations for the ages of 50 to 60. Now, let's take a look at some of the data that led to the approval for those RSV vaccine products. What we see on the slide was actually the preliminary data from the phase 3 clinical trials that the FDA and CDC reviewed. I will note that there actually have been some updates to these data. However, it doesn't significantly change our discussion. So they're within the same magnitude. And so generally what we see here with the Arexvy product in their phase 3 clinical trial was that in the first season, there was approximately an 80% vaccine efficacy against the endpoint of preventing RSV, lower respiratory tract disease, and RSV-related symptoms. That also extended to a second season. And so in the second season, there was a little bit of a drop, so there was some waning as we expect with any vaccine. So in the second season, though, it did still maintain a 56% vaccine efficacy. And again, this is preliminary data. There was some updated data that was recently released over the last month, but there aren't really significant changes. It's still within the same areas of magnitude. For the Pfizer vaccine, Abrysvio, very similar data from their phase 3 clinical trial as well. So for that particular product in the first season, there was a vaccine efficacy of about 80% or so. And in the second season, about a 78%. And I know it's tempting to compare apples to apples, but the 2 trials were done very differently. They looked at different endpoints. So you might be tempted to say, well, one looks a little bit better because it's higher vaccine efficacy, but they looked at different things in terms of their endpoint for how they defined lower respiratory tract infection and how many symptoms that they were looking for. So we can't really look at it kind of apples to apples, like that head-to-head comparison, because their studies were designed a little bit differently. So that's just one word of caution as we're taking a look at some of that data there. Oops, going back here. And then the newest product from Moderna, the mRNA RSV vaccine, was recently just reviewed, approved, and released onto the market. In their initial phase 3 clinical trial data, they found an 83% vaccine efficacy in its first season. There was some recent data that was released on their second season that was published, and it was roughly around 50% magnitude for the vaccine efficacy for that second season for the mRNA vaccine. But overall, as we take a look at the clinical trial data, we see that there's pretty good vaccine efficacy. And we also see that there is vaccine efficacy that's maintained in the second season. We're seeing numbers 50, 60, 70, 80% vaccine efficacy in the season 1 or season 2. And those are pretty good numbers. Just as a point of comparison, when we take a look at our annual influenza vaccine, that vaccine effectiveness changes year to year depending on how well it's matched. Sometimes we have 40%, sometimes we have 60%. And in most years, when we see a 60, 70%, we consider that to be a very good vaccine. So we're seeing some very similar numbers here with the RSV, and those numbers are really reassuring as far as it doing really well. Now, this slide summarizes the data from real-world observation data. So what we reviewed earlier was phase 3 clinical trial data. This is post-market surveillance data, and this is looking specifically at hospitalizations. And so that's what we're interested in, right? You heard from Dr. Jam. Hospitalizations are so important to prevent because when these patients get admitted, they're at higher risk for greater intensive care, for greater negative adverse outcomes. So preventing hospitalizations is great. The clinical trials, we looked at preventing infection. They didn't measure hospitalizations. They didn't measure death. But in the real world post-observational data on the bottom half of the slide, we were able to look at studies, or the CDC was able to look at studies to identify that, and we are seeing a vaccine effectiveness roughly in the 70 to 80% range as far as preventing hospitalizations. So that is incredibly reassuring. We always assume if we prevent infections, we prevent hospitalizations, and we see that that is true in this case with the RSV vaccine, with the post-marketing surveillance data studies that were being conducted. So the vaccine works. It's doing its job. So that's the efficacy part. The safety part, the vaccine safety profile is very expected. It's same safety profile as we expect with other vaccines, local site reactions, potential systemic reactions, et cetera, et cetera. But there were some early safety signals that came out of the phase 3 clinical trials, as well as post-marketing surveillance, that indicated there might have been some potential risk for Guillain-Barré syndrome, or GBS. Now, these studies and investigations are still ongoing, and there's still preliminary data that's being evaluated. So there is no final answer on this. However, because of the early safety signals, the CDC was able to hone in on that to investigate early on to determine if this is truly an issue or not. And as a part of that process with the Vaccine Data Safety Link, with VAERS and vSafe, they did their investigations to really identify, is this truly an issue with the vaccine, or is it a confounding factor with the kind of the background rate of GBS happening naturally? And the short answer is they don't know yet. So there's no clear answer. But we can see that there are some potentially elevated numbers of GBS cases related to vaccines. In some cases, it may be higher than the background rate. In some cases, it may not be, depending on which vaccine product we're talking about. And of note, the mRNA vaccine has not found any GBS cases in their clinical trials and post-marketing data surveillance so far either. But essentially, these are the numbers that you see with GBS. And just based on the current available data, there's still no clear statistical signal that this is an increased risk. So it is something that the CDC will continue to monitor, and something that will play a role in the decisions of whether they choose to recommend these vaccines for lower age groups or not. At the last meeting in June, the CDC did evaluate, did we want to recommend this in ages 50 to 60? But they determined no at this time because the risk-benefit profile wasn't clear to them. The risk of GBS was a little bit greater than the benefit of preventing cases for that particular age group with the available data. We are living in real time. This is a new vaccine that was just released. We're just in year 3 of the clinical trial data, year 2 of it being on the market. So this is still fresh information that they are going to be digesting, and that may change in the future as we get more final data, right? But that is an important thing to keep in mind is if you have a patient who has a history of GBS or high risk of GBS, you may want to just engage in that risk-benefit conversation with that patient to see if that is something that they may be concerned about. So overall, that was kind of the conclusion, is that there are no changes yet. There's no major statistical signals, but it is something that they will continue to monitor to see if that is something that we should be more aware of. Now, the other thing that you want to think about is timing and simultaneous vaccination and revaccination, right? So let's talk about all of that. So we know who needs to get the vaccine. So the next question is, when do they need to get the vaccine? So RSV is a seasonal respiratory disease. It actually mimics the seasonality of influenza. So October to March is really when RSV is most active. Now, when we think about when we want to give the RSV vaccine, the CDC actually recommends that it can be provided year-round. So there is no restriction on the time of year that you provide it. If the patient comes in January and they're asking for it, if they come in July and they're asking for it, they come in November, they're asking for it, you are able to give them the vaccine. Now, with that said, knowing that RSV infections follows a winter seasonality, it may be best to wait until roughly about the late summer to early fall to vaccinate certain patients. Because as we know, the efficacy of the vaccine wanes over time, right? So if you give it to someone too early, by the time the RSV infections are happening, it may not be as effective. So that's just something that you would have to consider. Are there restrictions on the time of year? No, you can give it any time you want. But if you can, it is preferable to wait, for late summer, early fall, so that they have the most optimal protection during the winter respiratory season. When would you consider some of those factors? Well, I think the big question is, will the patient come back? Is this a regular patient that you have who always seeks vaccines? If they're a reliable patient, if they're a regular patient, then yeah, I would wait and I would vaccinate them later when it's most optimal. But if this is a patient who comes once in a while, who you're amazed that they even said yes to a vaccine, just give it to them now. You don't want to lose that opportunity, right? So those are some of the considerations you might think about the timing of when that happens. The second consideration is, what about patients who already received the dose last year, right? So we have some patients, even though uptake wasn't as great, there are patients who received the dose last year. Those are likely your eager beavers, the ones who are pro-vaccines, who want every single dose possible. They're going to come back this year and be like, can I get my second dose of RSV? Well, they actually don't need that, right? So at this point in time, the recommendation is that it's a single dose of the RSV vaccine. Patients do not need to be revaccinated or receive a quote-unquote booster dose at this time. As we saw from the clinical trial data, they are following patients in seasons 2 and currently season 3, and we know that there is good efficacy data for at least 2 years at this point in time. Maybe there'll be 3 in the future. We don't know yet. But for right now, we know that it's good for 2 years, and that's good protection for this upcoming season. So for those patients who already received it last year, they do not need to be revaccinated. And another big consideration is, can I get my RSV vaccine with other vaccines? We're talking about a winter respiratory vaccine. You know what else is a winter respiratory vaccine? Influenza, COVID-19. And you know what else is a vaccine for our older populations? Shingles, right? So that's potentially 4 vaccines that a patient might need at that one single visit. Can we give them simultaneously if they're all indicated at the same time? And the answer is yes. Right? And it is encouraged whenever you can to give simultaneous co-administration at the same visit for any vaccines that are indicated for that particular patient. So RSV can be co-administered with RSV can be co-administered with COVID, flu, Shingrix, Tdap, and other vaccines that they might need. All right, so let's return to our polling question here. So let's rethink our choice for number 2. A 75-year-old man presents in May for his second dose of zoster vaccine. He asks if he can get an RSV vaccination at the same time. After congratulating him for being vigilant about his health, what would you tell him? 1, administering both doses at the same time, or same visit is contraindicated, and you should wait at least a week between shots. 2, RSV vaccination must take place closer to RSV season. He should come back in August. 3, later in the year would be preferred for an RSV vaccination, but you can have both shots today if he likes. And then 4, I'm not sure. So go ahead and scan the QR code and submit your answer, and we'll take a look to see what the response is. All right, wow, overwhelmingly, 94% for later in the year would be preferable for an RSV vaccination. but he can have both shots today if he likes, and I would agree with that as well. So as we discussed, RSV vaccine can happen any time of the year. However, if you can wait, that might be most optimal for some patients, and it depends on your evaluation. So I also would have accepted number two. Number two could have been the correct answer as well if you justified it, but I also agree with answer 3. Good job. All right, so some practical considerations for counseling. So we just want to counsel patients about side effects. So again, the safety profile is no different than any other vaccine. Talk about how it's mild, some of the expected side effects, but we do know that there's a preliminary potential safety signal for GBS for us to be aware of and to counsel those patients with maybe history of neurologic conditions. And then we also want to encourage patients and providers and pharmacists to report things to VAERS and vSafe. vSafe was used in COVID-19, but it's also now used in RSV, and that's another way for the CDC to monitor potential safety signals. And we should be encouraging our patients to report to vSafe for RSV vaccines as well this season. So back to Mr. B, the 82-year-old male widower of mixed race who lives independently in an over 85 community where he keeps himself physically active. His medical history is significant for hypertension and BPH. He goes to the pharmacy for annual flu, and the pharmacist discusses the option of RSV vaccination with him. So let's take a look at what variables we might affect our decision to give Mr. B an RSV vaccine. At first glance, he is definitely recommended. He's 82 years old. He meets the age-based recommendation for the RSV vaccine. He should definitely be getting it. But what if he reports today with a fever and reports having chills the night before? So that's often a question. What if my patient is sick today? Can they still receive the vaccine? The answer is actually yes. So mild acute illness is not a contraindication for vaccination. So if your patient's just a little bit sick and they come to the pharmacy asking for any vaccine, they can actually get it, and that's okay. If you want to wait and they want to wait, that's fine as well, but it's also appropriate to give at that visit. One of my former professors, Dr. Jeff Gold, who taught this, would say, if the patient's well enough to walk and talk in your pharmacy, they're well enough to receive a vaccine. So that's how I always view that. The next consideration is he's starting a chemo, radiation therapy, or other immunosuppressive therapy soon, including high-dose corticosteroids. Should he get the vaccine? And the answer is yes. Actually, immunocompromised conditions is a indication to receive RSV vaccine. So this isn't a reason why he shouldn't get it. It's a reason why he should get it. He's even higher risk for this disease, and he should definitely be getting that vaccine. When possible, you do want to try to provide the vaccinations at least 2 weeks prior to planned immunosuppression. So if they are starting some sort of therapy or whatnot, you do want to at least try to do that 2 weeks prior so they can build up the immunity before they become immunosuppressed. And then the last one is he got the RSV vaccine last year, and we already talked about that, right? There is no need to revaccinate. It is currently a single dose, and he should be protected with this current season from the dose he got last year. All right, we'll pass it back to Jam.
Thank you so much, Dr. Dang. I appreciate it. I'll get us started with the breaking barriers. So pharmacists-led strategies that we can incorporate to overcome vaccine hesitancy. So we are going to quickly meet Ms. C. Ms. C is a 73-year-old woman who does not speak English. She walks into the pharmacy for the first time seeking to have her prescriptions filled. The pharmacist notices her language barrier, engages another staff member that speaks the patient's primary language to help facilitate communication. And during the conversation, the pharmacist learns that Ms. C is unaware of the importance of RSV vaccination. So when we consider, who are those folks that are vaccinating? Well, it's pharmacists, right? Let's give ourselves a round of applause. So when we think about when we think about COVID-19 vaccines, more than 50% were given by pharmacists. Actually, greater than 80% of COVID-19 vaccines were provided by pharmacists. Influenza vaccines, about 60 to 70%. And then pneumococcal vaccines, we have about 40 to 50% being provided by us, by the pharmacists in practice. So what is it that we can do as pharmacists to optimize RSV, in particular uptake in older adults? Well, we can offer disease and vaccine information, which Dr. Dang and I have provided evidence on. So those high-risk comorbidities, what it is, the vaccines that are available, which ones would be most appropriate for them to receive. We can encourage individuals to receive them. So we can provide a strong recommendation. We can tell them this is a vaccine that works, that would be helpful for you to prevent, disease and further illness. We can determine whether co-administration with other vaccines they may be there to get is something that they can do. Dr. Dang talked really well about that. And then we can offer incentives for being up to date with that vaccination. So what are our big talking points that we can make sure to hone in on with our seasoned adults as we talk about RSV? Well, first, we can talk about complications. I find that sometimes we talk about those risks or how those risks can be amplified, then that can increase the willingness to uptake. We can make sure we bring up the fact that there is no current treatment for RSV. So the only way that they can protect themselves as of right now is to be vaccinated. We can talk about vaccine availability. So if you fall within that risk range, 60 to 74, if you're older than or equal to 75, then you are definitely someone that should consider this RSV vaccine. And then we can talk about eligibility. So the pharmacy team can come together and say, is this a person that's now an eligible candidate to go ahead and receive this vaccine? So what are our barriers that we come into when we consider these vaccine and vaccine uptake? Well, vaccine hesitancy. But the way that I like to think about vaccine hesitancy, especially as it's talked about in terms of those that identify as a part of a minoritized group, is oftentimes it's just the lack of vaccine literacy, that lack of disease-related education with actual fact-based information, and just minimal awareness. Folks may not even know that the vaccine exists, that it's available. Dr. Dang talked about the rapidly changing recommendations. It may be that folks aren't aware of those. So that's the important things that we have to consider. So while we might not have shared clinical decision-making before, I don't know. I guess I'm someone on the contrary. I think that we always have to take a collaborative approach when we approach healthcare. How many of us do things just because somebody told us to? I don't, right? No, you want to be able to have agency in your decision-making. So I think that us as, pharmacists, that's how we can approach this. Well, we can increase our vaccine-related discussions. We can say, have you heard about the RSV vaccine? Can I provide you some information on this? We can improve methods to identify our patients. So if you have folks that come in within these age groups, right? When I worked in the community, I knew my patients. I knew what diseases, comorbidities they have, right? We have those patients, right? You know their name. I still know my pharmacist's name. Go see him every so often, Dr. Paul at the CVS in Farmington Hills. And, and he knows, like, the comorbidities. He knows what it is we would interact with. So when they come in, you say, you know what, for Mr. Johnson, I'm going to make sure I bring up that RSV vaccine for him. Something that we can think about as pharmacists. We're not the most accessible healthcare provider for nothing, right? So now we're going to follow up with our polling question really quickly. So we have a 60-year-old patient, is a kidney transplant recipient, has type 2 diabetes. She's been informed about her eligibility for a vaccine, but declines. If I catch RSV, I'll just deal with it then. What do we tell her? 1, there are no treatments for RSV infection, and the immunosuppressants that she takes put her at increased risk. 2, you respect her decision, ask her to reconsider. 3, inquire if she has specific concerns. And then 4, I'm not sure. So go ahead, scan, and we'll quickly go through the answer. Okay, fantastic. I think that I would have gone for those two. I heard folks saying I'm at 1 and 3. So 1, and I think these are both things that we could do, right? We could say there are no treatments available for RSV infection. However, her immunosuppressants put her at elevated risk. I think that's definitely something, a strong recommendation we could make, right? And then also we can respect, like we talked about, that self-agency, her decision, but ask her to reconsider. And maybe that's an opportunity for us to bring in that conversation about the immunosuppressants, right? Okay, fantastic. Wonderful job, gang. We'll go ahead. So what can we do? And really thinking about that question, well, we can now, have that conversation about the RSV vaccine. We can do our motivational interviewing, right? We can ask open-ended questions. We can reflect and respond based on what it is that we receive. We can affirm the strengths, validate concerns that folks may have. Going back to the immunosuppressant example, we can validate, that the patient wants to wait and we'll deal with it then, but we can also bring up the facts about what the vaccine can provide. And then we can summarize and determine action following that conversation. So we'll go ahead to the next slide. But more importantly, what we as pharmacists can do is we can narrow vaccine equity gaps. As I told you all, I serve a primarily minoritized community base, and this is always something that I'm thinking about. So when we think about COVID-19, when we think about influenza, and now we're thinking about RSV, one thing that we continually see is decreased immunization uptake irrespective of increased risk of hospitalization, right? Morbidity, mortality. And this is not monolithic to these diseases. This is something that we historically see over minoritized communities. But us as pharmacists, we can be very proactive in overcoming these things. So when we are thinking of overcoming these things, then we definitely need to consider what are those different systems of oppression. And when I think about it in terms of, once again, going back to our minoritized groups, structural racism, right? How do they work and how do they compact to then influence our social determinants of health and then impact what we see in terms of vaccine equity? So when we think about education, racially and ethnically minoritized individuals are less likely to have opportunities to matriculate through higher levels of education, which can compromise vaccine literacy, right? Or knowing about the risk and benefits of vaccine. Socioeconomic status, well, we know that can impact accessibility to healthcare providers and the vaccines themselves. The environment, right, can increase disease transmission. So something that we need to think about. We talked about the multi-generational house, the housing with the grandparents and the grandchildren. I am someone that lived with my grandparent and my siblings and my parents, and it didn't matter what setting we lived in. All 5 wards, all 6 of us lived in the household together. And whatever disease that somebody else got, the whole house got it, right? The whole house was sick. And then our accessibility to healthcare services. Well, we talked about that education. We talked about socioeconomic status, but I also want to cue you in to the fact that racially and ethnically minoritized individuals are 3 times more likely to live in an area that's called medical desert, or that is now currently suffering a healthcare resource shortage. So that means that folks, even if they wanted to get the vaccine, may not have accessibility to it. So what can we as pharmacists do, and what is it that, I consider, or what I do in my practice, is one, we can provide community-tailored vaccine education, right? We can really attack that vaccine literacy barrier. And then we can think about low-barrier vaccination models that we can develop or partner with other folks with to make sure that we can increase accessibility. So within my research, and I work with a community organization, we developed what's called, a 3-tiered approach to address vaccine accessibility, in Black communities and to increase uptake. So we had 3 different tiers. Tier 1 was engaging with faith or community leaders. Tier 2 was providing education and tailoring that education to the specific community. And then Tier 3 was actually having low barrier or accessible clinics right there in the community directly following the education. So you don't let folks think about it too long. You get them, you give the education, you say, you know what, guess what? I got the vaccine right outside for you. Let's do it right now. So when we do so we provide the education, and with that education, we have the pastors facilitate that. They allow for us to come to the church, sometimes during the church service, maybe directly after. We do like a 45-minute lecture based on vaccine disease, benefits of receiving the vaccine. One thing that I prioritize in the education is really just information translation. I think that's our superpower as pharmacists, right? We quickly have to figure out, how do I make this relatable? So as I told you all, I'm going into the church community. So in particular, I'll talk about the influenza virus as an example. Instead of saying, we have these strains that we put in the vaccine, I instead say we have to identify those kids we have to pray for, right? And we have to put those in the vaccine. And one thing my mom always tells me is the kids you have to pray for, they may change from year to year. She says, well, last year I prayed for you. This year I'm praying for your brother. Next year I'll pray for your sister. If that's what it deems. But it lends itself to me being able to easily say, well, you got to get vaccinated every year, because the kids that we have to pray for, those strains that can cause infection, they may change from year to year. And that's one thing that the church folk understand, right? Well, we all have a kid that we have to keep in fervent prayer. For our family, is always my brother. So when we think about Tier 3, directly after that, we will do the low barrier vaccination clinics, which has been a staple with how it is that we approach this. And it really takes a lot of community partnership. So we partner with the county health department to go ahead and bring those vaccinations. But one thing that we do is we make sure that we increase accessibility. We put community health workers, but really we put members from the church that do the registration, they do the checkout. Because when you see, Sister Johnson, not just in church service, but you can see her in the capacity in which, she works. We have you have nurses and so on that are part of the church that would like to participate. The community, they love that. They love being able to see folks that look like them, provide them these healthcare services. So we also have our measurable outcomes, because at the end of the day, you can do an approach all you want to, but you still have to go back, revisit, tailor, making sure you're serving the community in the way in which you set out to. So when we started these vaccination clinics, I was with Loma Linda University at the time in San Bernardino. What we saw in our mass vaccination clinic site, we had the largest mass site in San Bernardino County at the time. We were vaccinating, a ton of folks that were of the non-minoritized groups, but we saw an excess of Black patients being hospitalized, and we had only vaccinated less than 5% of Black individuals in our mass clinic. Well, fast forward, after we instituted that 3-tiered approach, in our first clinic, we had vaccinated 351 Black individuals. About 84.2% of those folks were Black that were in that clinic. Well, guess what? That was drastically higher than what we saw in that mass site, but that's with the beauty of education and building trustworthy relationships, right? So what can we do as pharmacists? Well, we can identify, or what can we think about as strategies? We can identify individual factors that contribute to vaccine hesitancy, such as misinformation, mistrust, fear, complacency. While you all don't have to do it in the model in which I described, at the end of the day, we know how to take that information and relay it back to our community members. We can apply our principles of active listening. We can think about cultural religious beliefs. We can be sensitive in that, have cultural competency, debunk those myths and misconceptions with the facts that we know and the facts that we have. And we can help the patients secure affordable access, like I said, through that partnership, or say you all know of someone that's able to vaccinate in the community, you can direct them to where they can receive these accessible vaccines. So we are returning back to Miss C, 73-year-old woman who does not speak English, walks into the pharmacy for the first time, seeking to have her prescriptions filled. The pharmacist, noticing her language barrier, engages another staff member who speaks the patient's primary language in order to help facilitate. During the conversation, the pharmacist learns that Miss C is actually unaware of the importance of the vaccine. So using culturally and competent shared clinical decision-making approaches, how can pharmacists do the following? Identify candidates for RSV vaccination, educate and counsel patients regarding the risk of RSV and the safety and efficacy, and then provide additional protection for older adults against respiratory illness. More than anything, what we can do is summarize that by us going ahead and integrating those strategies that we approach, really thinking through and assessing, how it is that our patients present, we can ensure that we're identifying those ideal folks, but then also providing information and access in a way in which they can readily receive, and then go ahead and make the decision for themselves to be vaccinated. So in summary, we want to say that barriers to vaccination in older adults can include, a lack of a strong recommendation or limited understanding of risk and morbidity, as well as understanding the benefits of vaccines. The vaccine disparities can be prominent across racial and ethnic minoritized groups. However, we can think through creative strategies to promote equitable access to these vaccinations and education. So we will go ahead and roll back our conversation and allow for you all to ask any questions.
We did receive some questions. I will read those off. Dr. Jam, if you have the answer, feel free to chime in too.
100%.
So the first question we received is, if it's only recommended for patients to receive one vaccine and be done, why would it have an optimal time of administration? That's a really great question. So I would kind of break those down into two different concepts to think about. The first part is, why is there an optimal time if you can still give it year-round? I think it's about giving your patients the best bang for their buck for the upcoming season. And then for the second season, something is better than nothing is what we would look at, right? So if you can optimize it, go ahead and do that. But why would it be right now one and done? So we did see the clinical trials where they did see in season 2 that there was vaccine efficacy, even though it was dropping, right? So you saw that dropping and waning efficacy, and you might say, well, I think we should give them a second dose. Wouldn't that boost it up? So actually, GSK did do a revaccination study, and in that study, they found that there was no increase in vaccine efficacy with a second dose. And so at that point, it would kind of become a waste of resources. You're giving someone something that doesn't give them any benefit. So at this point in time, the data from that particular study showed that a revaccination 1 year later did not provide any additional benefit when it came to vaccine efficacy. It actually resulted in the same or similar number. And so that might change later on. Maybe they do a study where there's a second year or a third year. We don't know yet, but those are the two different concepts I think I would keep in mind. But that was a very excellent question.
In reference to the multiple vaccinations, when you were talking about it's okay to do the multiple vaccinations, since you did hold a clinic, what is your best practice in reference to multiple vaccination? Are you like 2 in one arm, 2 in the other?
Sure.
Are you the quadrant method?
Yeah,
what is your best
great question. So when we did co-administration for multiple vaccines at our clinic, we do an international travel clinic, and on average, patients are getting 4 to 6 shots per visit. So we encountered this a lot. And so the way we would approach it is we would do 2 intramuscular injections per deltoid muscle, and 1 subcutaneous injection per arm would be our maximum that we would do within the clinic. There's some who might say 3 intramuscular, but we always went with 2 intramuscular per arm. And we would have them spaced 1 inch apart, and you can do them either vertically or horizontally depending on your preference, but we always did a vertical spacing 1 inch apart for the 2 intramuscular. So theoretically, our clinic max was 4 IMs and 2 sub-Qs per visit. Yeah. Dr. Jam?
Yeah, so we do co-administer in my clinics as well, but we only give the COVID-19 and influenza vaccines, so we're only giving 2. I will often tell folks to do 2 separate arms, and then honestly, it's just because of my own individual preference. I don't do both vaccines in the same arm, and I would hate to tell someone to do something that I'm unwilling to do. And that's just because, I don't want one arm to be out of the count. I'm like, let's spread out the joy.
Yeah.
So that's typically what we will do. But I have had patients that will come back and tell me that they went and received multiple vaccinations, even more than the 2. Yeah. And what they've told me they've done is the 1 inch apart, maybe 2 vaccines here, an additional one in the opposite arm. So I think, too, also asking the patient, how would they prefer to feel, the next day? Do you want one arm out of the count? Would you like to distribute, how it is that you receive?
On the other end of the spectrum, I'm just give it all in one arm, because if I'm going to be out, I want one arm to be out.
Why didn't you correct feet?
Great. There are some questions in the system. I don't know the answer to this one, but maybe someone in the audience or Dr. Jam knows. Mm-hmm. Do you know if pharmacies like CVS or Rite Aid have automatic alerts placed to identify patients who meet the criteria for vaccination so that it prompts the pharmacist to have a discussion?
Oh, wow.
Some do. Yep. I'm assuming some do. Yeah. With an existing patient who's in your profile, based on the medications they have, some inferred diagnoses and age, there might be prompts that pop up. So it sounds like some of our companies that you work for do have those systems in place, which is a great reminder. Yeah. In hospitals, yep. Especially upon discharge and admission, yeah. There's another question in the system, Dr. Jam. What do you see as the biggest obstacle to vaccine uptake?
In my community, I feel like what I believe would be the biggest obstacle is just the lack of perceived risk and the lack of perceived benefit to the vaccines, which I think is really a testament to just a limitation in vaccine literacy. So, and then honestly, I think I would have said that was the biggest risk when we initially had the rollout of certain vaccines before we started this intervention, which we've been doing since 2021. Now it's becoming more of an accessibility type of thing. So, when COVID-19, as we move through the pandemic, the concern and more importantly, the dollars that have been put towards the efforts that were previously rolled out have significantly decreased. So like the outreach and even the way that I'm able to provide vaccines has changed rapidly, over these last 3 years. So now I'll have folks that are willing to get the vaccine. So for instance, I provided education about COVID-19, and typically it would be, folks saying, oh my goodness, why do we have to get the vaccine, blah, blah, it'd be a lot of back and forth and, and the willingness to get it. when I went back, so that was in 2021. In 2023, when we did the intervention, I actually got no questions about COVID-19 once I was given information about the subject. And the only question I got was, do you have the vaccine with you here today, right now? So as you all know, that is not a typical question that you expect to receive, right, when you're going into the community. And I had 50 people that were willing and ready to get the updated COVID-19 vaccine. However, I was in a very contentious battle with the county about how it is that we would be able to get the vaccines there for the community, and if they were willing to provide them to those folks that were uninsured. So I think instead of it being really like a vaccine literacy or vaccine hesitancy being the big conversation piece, especially for minoritized communities, it was more so an accessibility limitation.
Following up, with what you said, how did you get the county to provide those vaccines for, say, homeless or the uninsured?
Begging and pleading. But I mean, honestly, it kind of was that. But what it was I actually reached out to Governor Gavin Newsom. I reached out to his office, and I told them about what we were doing, and I asked them if they would be willing to support. I actually partnered with a community organization to do the work, and they had, we used their connection, we leveraged their connection with the governor's office, and then the governor's office then kind of fast-tracked us to the Department of Public Health, the San Bernardino County Department of Public Health, and through us being connected and them being the facilitator, right, of the connection, they immediately jumped in and they said, well, we were trying to find a community, right, to collaborate with and provide, vaccines to, so on and so forth. And then we were able to then partner together. And because the partnership was successful during that time frame, they were ready, they were excited to then move forward this year with the collaboration. But honestly, it's taken a lot of humility, first and foremost, to partner with the county and to understand that they have their own set of protocols and patience, and so on. But I think that by continuing to showcase the need, then they were then on board to say, okay, we can see that this is definitely a limitation and we would want to invest to help support it.
Thank you.
I see another hand up and the microphone's going over there.
And I just want to commend you on having metrics. A lot of people don't think about, once you implement these type of programs, how important it is to measure the success. And I think that also helps to having programs like this, spread out. I'm in the research area. That's why I'm saying this to you. Having those metrics to be able to show that benefit and be able to take that allows for these programs to be expanded across.
100%.
Kudos to that.
And what I didn't say is that I do have research attached to the intervention. So the churches receive $1,000 for hosting. So we do it at 5 churches. I do it from August to December. They receive $1,000 for hosting. And then the participants in the survey receive a $20 gift card to a grocer. So we give incentives. But the only reason that I've been able to probably have the success or continue to keep going is because the initial intervention was published in the Lancet, and the pastors were included as authors on the paper that I published because they're the reason that we were able to be successful. But through them having that buy-in and that engagement, it allowed for that continued investment. And then we've continued to publish the data. So when we went to the governor's office, we had peer-reviewed in top, cited journals, the research that we were doing for the community. That's really allowed for us to propel it forward.
So there's a question, is there an upper age limit? So if you have a patient who's 90, mid-90s, can you recommend the vaccine? Short answer is yes. Actually, if they are 90s and above, they are probably at higher risk. They might be considered frail. They might be living in a congregate living facility. And we do know that the older you are, the higher your risk for RSV complications. So yes, they should be recommended, and there is no upper age limit at this time. Then there was a question or comment about the cost of the vaccine, noting that it's expensive and in some areas it might not have been covered. So I think that's something that should be resolved. It's actually required by the federal government that health plans who are in the ACA cover all routinely recommended CDC vaccines. So I think a few things. One, when the vaccine was new, there's a lag time for insurances to get that coverage to be kicked in. So we saw some of that happening. But two, now with the new ACIP recommendations, it is clear, right? Before it was shared clinical decision-making, and some health plans were like, well, that's not routine. Well, the CDC changed their recommendations to be, yes, it is age-based and risk-based. It is a routine recommendation. So we should start seeing some of that phased in where those should be covered by health plans, and it is covered under Medicare Part D, for example, as well. And then there's a hand up.
I was also just going to mention, hi, you guys did a fantastic job, by the way.
Thank you.
Thank you so much for all of the information and all of your advocacy work on both sides. California is really, the main place where pharmacists are doing this incredible work and really getting to where the people are. So the one comment that I did want to make in support of the CDC and ACIP's changing these recommendations is the fact that the Inflation Reduction Act requires the payment of this vaccine as well, which was age-based. So there's this gap between the 60 and 64-year-old range where folks were not getting it covered. So now that they have changed this, I do think that you'll have more folks being able to get covered, even though you do see the ACA recommended plans stating that they need to cover it because it was under shared clinical decision-making, they could still deny coverage. Yep. So I just wanted to make that point.
Yeah, thank you.
Guys.
All right, I believe that was our last question and comment. Thank you so much for joining us.